Good morning. I just want to echo what a privilege and honor it is to be with you this morning. I think patients who have had a visit with us will know that one of the things I always say to a new patient is, have you visited the Chordoma Foundation website? It is such a resource, and it's an honor and privilege to be associated with such a wonderful and excellent organization. I've been asked to talk a little bit about the state-of-art of proton therapy. So what I'd like to do is maybe focus on some aspects of proton therapy that I think is really relevant for the chordoma community. And that is the idea of repeat radiation. Over the years, this idea of salvage radiation therapy has really taken its own. And from perhaps when I first started getting involved with this, where it was taboo, it was really malpractice to do this. And I remember when I first started doing this at Sloan Kettering, every one of my re-irradiation cases had to be reviewed by a committee because the hospital was so worried about lawsuits. And it's really been an uphill battle. But now I think that in the radiation oncology community, with the technology that we have, re-irradiation has really become an accepted standard practice paradigm, and especially, I think, relevant in the chordoma community where so many patients have radiation. And as you've seen from the data, recurrence of chordoma is one of the biggest clinical challenges that we face, whether you're a surgeon, a radiation oncologist, or a medical oncologist. So I'd like to just focus a little bit about the state of the art, so to speak, with proton therapy for re-irradiation, because the whole idea of what is state of art in proton therapy is too big for the time allotted for this. So let me just go back a little bit and talk about our experience that we've had over the years with re-irradiation of resistant spine tumors, and maybe take that experience as an introduction on how we think about re-irradiation for chordomas. So this is a paper that we published with Dr. Loeffler. There he is. Yeah, he was the first author on this paper. And what I want to emphasize out of this is that what we realized is that when you use high dose per fraction paradigms, it didn't matter if there was a prior course of radiation. The outcomes are exactly the same. And if you had a tumor that was irradiated in the spine with radiation treatment and grew back, I think you would agree with me, by definition, is radioresistant. Just like an infection, that comes back after the antibiotics, it's resistant to the treatment. Dr. Loeffler looked at this, at our experience, and if you level the playing field with separation surgery, which is removing the tumor around the spinal cord, whether or not you'd had radiation before or after made no difference if you used an appropriate radiation paradigm. In this case, high dose per fraction radiation and a limited number of fractions was equally effective in killing these tumors regardless of whether they had previously seen radiation or not. And that has to do a lot with the biology of high dose per fraction radiation. And most patients who had chordomas over the years have been treated with standard fraction radiation, small doses of radiation, about 1.8 to 2 gray per fraction, over an extended period of time. And we've actually seen in our experience that you can take patients who had these type of more conventional treatments, treat them with stereotactic body radiation, which we call SBRT, which really, in essence, is highly concentrated radiation dose that's with high precision targeting. And that if we do that, we can overcome radioresistance. And so the term radioresistance in the 21st century is starting to lose its meaning, because it's not so much what's resistant to radiation, it's like, are you using the right paradigm to treat the tumor? And if you are, then the resistance is really less of an issue, because you can ablate tumors if you use the appropriate radiation paradigm. And so this is what this paper made us start thinking about in terms of how do we salvage patients who had recurred after radiation. And in fact, we can actually re-irradiate patients who have failed SBRT. So these patients who have tumors that are so tough that they've they've grown back after high dose per fraction radiation, we can still offer those patients about, I don't know, about an 80% chance in the long term of durable tumor control with another course of stereotactic radiation. Not all these patients, some of these patients in this abstract are chordomas, most of them are not, but I think by definition they're all radioresistant. So with proton radiation, where are we? In terms of re-irradiation, I want to give you some of our thoughts of what we think the future is going to look like with proton-based stereotactic radiation. So this is a little different paradigm than traditional proton beam radiation, which is giving a small dose per fraction over a period of 7+ weeks of therapy. This is in 1 week or less, 1 fraction or up to 5 fractions of radiation for re-irradiation of patients. As I was saying, stereotactic radiation is ablative in nature. In fact, one of the first cases where we actually thought that it could be ablative was a chordoma patient that we treated with stereotactic radiosurgery. A little higher doses than I think we can give in the skull base. This is in the low spine. We treated with 24 grain a single fraction, and that tumor essentially became necrosis. That we can re-irradiate, I show you, and the proton radiation has this one special thing that I think many of you are aware of called the Bragg peak effect. And when you scan a tumor with protons, you can take advantage of the Bragg peak effect to limit the radiation dose to any tissues that are behind the tumor. And essentially, the modern proton machines are now filling. It's like a scanning beam that scans the tumor and essentially fills it with protons that have this Bragg peak effect, where the biologic impact is extremely high. So we really think that from a dosimetric perspective, there's a real role for proton-based stereotactic radiation using high doses per fraction to overcome radioresistance while taking advantage of the proton beam's special characteristic of no exit dose. So we're actually doing a number of treatment planning studies right now, taking patients that I treated with radiosurgery at Sloan Kettering and transferring those treatment plans to our proton center and asking the planning physicists to come up with the exact same doses of radiation, not with photons, but with protons. And is that even possible? Well, this is actually one of the questions we're asking, because we know that the power of high dose per fraction radiation beginning to ablate a chordoma is important. And if we can take advantage, the dosimetric advantage of protons, but the biologic benefit of high dose per fraction, we may actually have a winner. So this is what we're working on. So here on this side is the photon-based plan. This is a T7 tumor, and one of our big problems is the esophagus. And so the question is, can we spare the esophagus by using proton beam radiation in a patient who has previously been treated and seen high doses of radiation to the esophagus? This is the 5% dose level. This is a color wash showing the radiation dose in blue at 5% or higher for photons and for protons. This is a 5-beam proton plan. You can see that the esophagus color wash is significantly lower than it is for the photons. And if you go to the higher doses, this is the 50% isodose color wash. Again, you can see why the protons might actually be much safer for the esophagus than it would be with the photon plan, without sacrificing coverage of the tumor and keeping the spinal cord to the same safe level. This is what we call a dose volume histogram. It's a summary, and it's a pictogram showing a summary of radiation doses, the different structures in the radiation field. So up here, this is the the planning target volume is actually the target we're trying to treat for this T7 tumor, showing that there's no sacrifice in how well the tumor is covered with either protons or photons. And then the dark blue lines are the spinal cord doses that accumulate to the spinal cord for this treatment with protons and photons. The spinal cord dose actually is not that different. Where do we get the biggest savings? It's using the Bragg peak benefit to limit the radiation dose beyond the tumor with protons, keeping the esophagus dose significantly lower. Right now, when I treat patients with photon-based radiosurgery, I'll tell patients, you're going to have the worst sore throat you've ever had because of the proximity of the esophagus to the spine. And with proton-based radiation, that may no longer be necessary. So, just again, sorry, this is really interesting to a radiation oncologist. I recognize that some of you are not headed to radiation oncology school, but just to again show that there are significant dose savings for a structure like the esophagus with implementing protons. Now let me just, so that's the dosimetry part, the physical radiation doses. There is certainly room to think there's going to be an advantage with the physical radiation doses given to structures in the body. What are there other savings? Well, one of the most fascinating things is this idea of flash radiotherapy. And this is a phenomenon known really since the early 1960s, is that if you give the same dose of radiation to a tissue, but give it much faster than you would with conventional radiation treatment, that there's a significant savings in how the radiation affects that tissue. How fast are we talking about? Well, it's about 400 times faster than standard radiation. So you give this much radiation with conventional radiation, it's about 5 gray per minute. You give the same amount of radiation 400 times faster, okay, it's about 40 gray per second. It's a magnitude difference in how quickly the radiation gets in there. If you can give the radiation that quickly, there's actually significant less radiation effect on normal tissues. This is kind of crazy. We don't understand why that is, but we know it's a real phenomenon. So I'm going to show you a little data, mainly in mice, all in mice actually. So if you're a mouse, you have nothing to worry about. Your brain after radiation is going to be just fine. But this is really fascinating for us and how we might be able to take advantage of this for patients, especially who are needing a repeat course of radiation. So for example, if you give 8 gray, which is amount of radiation dose to the whole brain of a mouse in flash, compared to conventional radiation, there was 0 effect on that mouse's neurocognitive functioning. And don't ask me how they measured neurocognitive functioning in a mouse. I don't know. I don't know if you just showed a piece of cheese and see what it does, but somehow they figured that out. But this holds true in all kinds of tissues in the body, whether it's a neural tissue like the brain or the nerves, in the bowel, which is extremely sensitive to radiation, or the lungs. There is a significant savings in complications by using flash radiation. So, if there's a significant savings in radiation effect in the normal tissues of flash, what about the tumor? Are you also going to lose the benefit of radiation in tumor control by using flash? Well, we wouldn't be talking about it if that were true. Interestingly, there is no flash effect in tumor cells. Only in the good normal tissues is there a flash response. So you do not lose any possibility of tumor control by giving the radiation in a flash manner. but you gain a significant savings, up to a 50% reduction in radiation effect by using flash. So here's just a bunch of experiments showing that by giving those similar doses that there's significant less radiation, or there's no loss in tumor control. So here's one experiment, and on this side, this is no radiation, and on this side, this is tumor volume, how big the tumor is over time. So, you know, if you give no radiation, the tumor keeps growing. If you give radiation, whether it's flash or conventional, the exact same dose, there's no difference in the tumor response. And here, again, the non-irradiated tumor, the blue line is the conventional radiation, and then these are different flash schedules showing that there's no real significant difference in tumor response. You don't sacrifice by using the flash technique. However, what you do see is significant less side effects from the radiation. So this was a standard rate radiation, 0.9 gray per second versus flash, 78 gray per second. Okay, looking at the bowel effects on the bowel, which is extremely sensitive to radiation effects. And so they looked at the number of normal cells that are left after radiation, how quickly those cells, new cells, come back, and then the amount of scarring, which is measured by how thick the bowel is after radiation. What they found is that there's significant sparing of the cells that repopulate the bowel with flash without any difference. Without any difference in terms of the response to tumors. So if you look at this panel, this is how thick the bowel is. Okay. Significant sparing for flash compared to, it's almost the same as no radiation here, the amount of scarring. This is conventional radiation. Okay, this is the number of cells that regenerate after radiation. Okay, this is no radiation. Okay, this is conventional radiation, and this is flash. So there appears to be a real effect, and this shows the same experiment with the tumor, showing there's no difference in tumor response. This is no radiation. The red is conventional radiation, and then the green is flash. So there's no difference in the tumor response. It does respond, and there's significant normal tissue sparing. Why are we talking about this for protons? Because it's really the one, we do not have the technology with conventional photon or X-ray based radiation to give radiation this quickly. But we can do it with protons. We can do it today. I hope I was able to show you that there's a significant dosimetric or physical dose advantage with the Bragg peak effect with protons. You can spare things like the esophagus, radiation risk to the lungs, pneumonitis, and even bowel toxicity can be saved simply because of the physical properties of proton radiation in the body. And I hope I was able to show you that there's real tremendous promise by using flash radiation. We can reduce toxicity by about 50% of equivalent dose by giving the radiation 400 times faster than we can with conventional radiation. But unfortunately, proton radiation may be the only technology that we have to give the radiation this fast. So it can be the ideal platform for re-irradiation because of the normal tissue sparing effect without sacrifice of tumor control. We might even be able to improve our outcomes by increasing the radiation dose to the tumor without increasing the risk of complications, especially in the re-irradiation setting. There are a number of technical challenges with this. This is still an ongoing work in progress. So I guess it's not even the level of cutting edge. It's like even before that. There's a tremendous amount of research and work going into making this a reality for our patients. But I just feel that the potential for this is great, and the benefit for our chordoma patients in the re-irradiation setting simply just cannot be understated. I think I'll just stop there. There are a number of technical challenges that we're working on. These are some of the research avenues that we and our colleagues around the country or around the world are working on to make flash radiation therapy a reality. Thanks so much for your attention.